Everyone. So we will be starting shortly.
Good afternoon.
Good afternoon, ma'am.
Good afternoon, Anil. Am I audible?
Yes, ma'am, you are audible.
Okay, thank you.
Namaskar, Anilji. Is it okay from my side?
Sir. Yes, sir, you are audible, sir, perfectly.
Audio, video, both?
Yes, sir, both are perfect.
Good. Good afternoon, Dr. Pereira.
Good afternoon, sir.
Nice to see you.
Likewise, pleasure is all ours.
Good afternoon, sir.
Very good afternoon.
After a long time, I'm seeing you.
Great
When
to
you're
see you.
director at the National Vector-Borne Disease Program, that time I came to see you.
Right. So presently you are back to India.
Yes.
Left.
Now,
Korea.
for last 5 years, I'm just in Delhi.
Great. So no more vaccine now. That remains the interest.
More into emergency public health now. So that
Good.
time, I was exclusively focusing on vaccine clinical trials.
So which place is your office nowadays?
It's a temporary office facility in Goal Market, Metropolitan.
Metropolitan, right. There are two blocks, no? Metropolitan Hotel and nearby accommodation. RD is sitting in Metropolitan and some of the regional advisors, they are in another building.
In the building nearby.
Right. So you are in Metropolitan.
Yes, sir.
Good, great. Close to RD. Right. We will meet someday then.
That's right, yeah.
Yeah.
Good afternoon, Rajesh, sir.
Good afternoon.
Sir, shall we start?
Yeah, please.
Okay, sir. So a very good afternoon to all the distinguished dignitaries, panelists, and our participants who have joined us in today's webinar on overview of WHO's Public Health Emergency Operations Centers Framework and Global Common Minimum Standards. And I am Anil Kathet, Technical Officer, Emergency Management, VHS CDC India. And I welcome you all to this event that is being organized by three prestigious organizations, National Institute of Disaster Management, Ministry of Home Affairs, Government of India, and National Center for Disease Control, Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India, and US Center for Disease Control and Prevention, Country Office, India. So this is the fifth webinar of 12 webinar series on public health emergency and disaster management during and beyond COVID-19 for building a resilient workforce system infrastructure in India. And this 12 webinar series, it is envisaged under the guidance of patrons Shri Taj Hassan, IPS Executive Director, NIDM, Dr. Sujit K. Singh, Director, NCDC, and Dr. Meghna Desai, Country Director, CDC, Country Office, India. And the co-chairs of this webinar series are Professor Surya Prakash, Head GMR and CBRN Division and IDM, Dr. Himanshu Chauhan, Joint Director and Office in Charge, IDSP and NCDC, Directorate General of Health Services, and Dr. Rajiv Sharma, Public Health Specialist and Lead Emergency Management, CDC India. And just giving overview of our last four webinars. In the previous four webinars of this series, we covered response and management of COVID-19 pandemic, and when one webinar was on coordination, multi-layered, multi-sectoral and multi-agency coordination focusing COVID-19, and our expert also provide insights on legislation and policy framework to deal with disasters and public health emergencies. And last week we discussed about the management of public health emergencies, and we also focus our discussion on public health emergency operation centers. And today, taking it further, today we will be learning more about this global common minimum standards for public health emergency operation centers, beside the framework of World Health Organizations for public health emergency operation centers. And for that, renowned experts like Dr. Sugandhika Pereira, who is a program area manager of emergency operations, WHO Health Emergency Program, and Dr. Anil Bhola, who is also from WHO Health Emergency Program, and Dr. Akshay Dhariwal, who is Advisor Emergency Management, VHS CDC, and he is also the former Director in CDC, Government of India. So these are the experts for our sessions. And without further delay, now I pass on the stage to Dr. Rajiv Sharma, Public Health Specialist and Lead Emergency Management, CDC India. He is one of the chair of this webinar series, and request sir to set the foundation of today's webinar with his introductory remarks. So with these words, I pass on the stage to you, sir. Over to you, sir.
Thank you, Anil ji. Am I audible?
Yes, sir, you are audible.
Yeah, thank you. Namaskar, good afternoon, good evening, and good morning to all the online learning community network partners and colleagues. As many of the our online learning community members are from other countries, so based on geographic location, time difference, this is a great initiative of three institutions in India. As Anil ji has already given an overview of these webinar series, in that continuation, I would like to add further that this webinar series is intended to focus on sharing tools, knowledge, best practices, and experiences in developing and implementing public health emergency management professional development program, public health emergency operation centers, and use and application of incident management systems principles through a concept of operation. And this means, policies, roles, responsibilities, and how the structural and functional elements of the organization or agencies, will work together for effective coordination of responding, responding agencies from different sectors at multi-layered, multi-agency, and multi-ministerial response, which already we have covered in previous webinar series, that how to connect various agencies for an effective response. And now coming back to the today's session, like the WHO incident management system, this is again based on a global experience and global best practices. It provides a management structure and a set of protocols for operations, planning, logistics, finance, and administration. At today's webinar, Mr. Anilji has mentioned 5 by 12. So this is the 5th webinar in 12 webinar series. And we have distinguished speakers, Dr. Akshay Dhariwal, former director of NCDC and NBBDCP, Ministry of Health, Family Welfare, Government of India, Dr. Sugandhika Pereira, and Dr. Anil Bhola, colleagues from WHO Regional Office for Southeast Asia. I would also like to thanks to Dr. Nilesh Buddha, lead regional emergencies or WHO health emergency program, WHO regional office, for his continuous guidance, support, and coordination of for this webinar. Speakers have been requested to share the WHO framework of PHEOC, as there is a a revised version is also underway soon. That revised PHEOC framework will be in public domain, and also requested for available resources for development and implementation of the network of PHEOC, so that a national, regional, and a global network is established for sharing real-time information, resources, and expertise. With this, looking forward to hear from our respected speakers and request for an active participation of our online learning community to learn from this session and ask questions to the speaker, so that there is an active two-way communication with the speaker and the participants. With this, all the best, and thank you, Anilji. Over to you.
Thank you very much, sir, for your remarks. That your remarks will serve as a foundation to our experts to further consolidate the objectives of this webinar series, which is to strengthen the public health emergency management in the country. And your words will also help them to connect their talk with the visions of this webinar. So once again, thank you very much, sir. So moving further for the technical sessions, like Sir Rajiv sir have also mentioned that participants are requested to share their questions, their queries, and for that sharing their queries, they can use either chat box or they can use Q&A box. Your relevant queries will make this session more interesting and as well as learning one. So the first presentation, it will be from World Health Organization officials, and from WHO, we have with us Dr. Sugandhika Pereira. And ma'am is Program Area Manager, Emergency Operations, W Health Organization Health Emergency Program, Regional Office for Southeast Asia. And ma'am has decades of experience in the field of emergency management at national as well as international level. And for this talk, Dr. Sugandhika will be joined by Dr. Anil Bhola, who is Consultant Emergency Operation, WHO Health Emergency Program. And Dr. Bhola has earned extensive experience and in-depth understanding of the ground realities in the field of epidemiology, health system strengthening, testing innovative hypotheses, and strategy development for better public outcomes. And the officials from WHO, they will be talking about WHO's framework on public health emergency operation centers. So what are the common minimum standards? And this is to inform our experts that for this presentation, you both have 40 minutes, total of 40 minutes. So with this words, I pass on the stage to our experts. Over to you, ma'am.
Thank you very much, Anil. Yes, thank you. If you can share, please. First of all, good morning, good afternoon, good evening, sir, madam, colleague. It's an absolute pleasure to be here with you this afternoon. And first of all, let me extend my appreciation to the National Institute of Disaster Management, the National Center for Disease Control of the Government of India, and also the US Centers for Disease Control and Prevention India Country Office for inviting WHO Regional Office to be a part of this webinar series. So thank you very much for that. And let us share a few thoughts from my end with regard to this Public Health Operations Center. Next slide, please. So Anil Bola and I will do a joint presentation. We will initially take you through some of the concepts of public health emergency operations centers, share a little bit of PHEOCs in the Southeast Asia region, and finally introduce the framework for PHEOC of WHO. Next slide, please, Anil. Thank you. So all of us are involved in emergency preparedness and response. And if you hear the word emergency operations center, and if you close your eyes, it basically, the thoughts take you to a room where you have a very busy room, where you have a lot of people, screens, monitors, maybe TVs running, telephones ringing, people walking here and there. There's busy discussions going on, sometimes even a little bit chaotic sometimes. So this is the kind of picture that we get if we talk immediately, if we hear the word emergency operations center. And actually, there are many concepts, principles, practices, protocols behind this picture that you visualize when you hear the word EOC. The Public Health Emergency Operations Center to us is basically a tool in the broader public health emergency management system of any context. And it's basically a tool which integrates the health services into the overall national or subnational, whatever the context is, the contextual emergency management model. And though we initially get the initial feeling that this is during response, the PHEOC concept and its functions are beyond the response phase and the recovery phase, but it's also throughout the entire spectrum of emergency management. It's basically a few thoughts on EOCs. So it's basically a location where plans are made for response, where resources are pooled, and certain emergency management functions are performed. But initially, though we think it's a physical location, the last 2.5 years have taught us that it can be a completely virtual space. And also for WHO, we all know about the international health regulations, and public health emergency operations centers is a core requirement under the National Emergency Preparedness Framework or under the IHR. It's an information center where this information feeds into strategic decision making and provides the basis or the platform for the coordination. So overall, the EOC is, despite that very busy picture you have of a room, it's basically a collection of many things. It's a collection of people, infrastructure, protocols, etc., basically to create an effective way to achieve coordination among agencies or partners while responding to an emergency. Next slide, please. There are many objectives of establishing and implementing a public health emergency operations center. These are some among the many such objectives. The first one is basically it provides the platform for operational decision making in a timely and event-specific manner. It provides the platform for communication and coordination with response with partners, coordination with partners, developing response plans. It is basically the platform for data and information management, from collection to collation to analysis and presentation. It's a platform where you deploy response resources. Resources are mapped and then they're deployed. And also a platform where you monitor the financial commitments and provide administrative services which are essential in any part of the emergency response. Next slide, please. Yes, one more. There's a diagram there with me. So like Rajiv mentioned, PHEOCs is closely related to the incident management system. If you can, yes, please, thank you. So the Incident Management System and Public Health Emergency Operations Center are two concepts that go very close hand in hand. We cannot talk about one without the other, essentially. And Incident Management System is basically the foundation you create to respond, be it a small-scale emergency, a large-scale emergency, emergency of any hazard, all hazards. Basically, you need some kind of an incident management system to respond. It's a critical part of the public health emergency management broader program. And the Public Health Emergency Operations Center basically provides a platform that helps the IMS to function. So these two are basically two concepts which are very tightly associated. And here I have just mentioned 5 minimal or critical functions within the incident management system that is supported by PHEOCs. This can be horizontally or vertically expanded based on the requirement, length and breadth of the emergency, context, as well as the need. Now, for example, for WHO, we, along with these critical 5 functions, we also have a function of partnerships, because for us, partnerships is critical. And so that is just a brief about the IMS and the relationship and the connection with the PHEOC, because these two are essentially very closely linked. Next slide, please. Yes, if you can press one more time, Anil. So the role of H1, 2, 3, yes, 3 more times, one more, thank you. So the PHEOC is basically a part of this multi-layered and multi-stakeholder broad emergency management, broader national or subnational level framework. As you know, at the strategic or the policy level, you have the higher level coordination groups, the steering committees, policy groups, etc., which generally comes under the mandate of national disaster management authorities. And below that, in the next level, the operational level, where you get a lot of emergency operation centers. And the Public Health Emergency Operation Center of national or subnational level is basically, that's where it fits into. And there is very strong horizontal collaboration with the other EOCs based on the emergency and the need. For example, the civil defense, the military, it could be the irrigation, it could be water supply, I mean, whatever the partner is as relevant to the emergency. And also, there's another lower level, the more tactical level, the field level, where you can also establish public health emergency operation centers based on the need to coordinate with the field level emergency operation centers of other sectors. So for any public health emergency operations center network to function, it has to collaborate very closely horizontally as well as vertically. Though PHEOCs could be within the health sector, it needs close collaboration with all the other sectors as well. And these are some of the fundamental things that we need to remember when we go through the framework. Next slide, please. So just to share a few in the region what have happened and where things are and how we have also supported and worked with our partners and member states in strengthening health emergency operation centers in the region. WHO has been working in this area for over a decade and advocating for the establishment of health emergency operations centers at national and subnational level. And several regional and national level workshops, meetings, capacity building activities have been carried out extensively. As you know, for WHO in our Southeast Asia region, we have 11 country officers, and all 11 country officers, there are public health emergency operations centers at national level. And in many, you have subnational level health emergency operations centers as well. They look very different to one another. These have been basically set up tailor-made to the context and based on the needs and the requirements. And even for us within our organizations, as a part of our readiness and business continuity planning, the processes related to public health emergency operations have been set in place quite strongly. And during the last 2 years, I think this entire network came into the picture where this became the heart of all operations in every and any context across our region. Here I have just shown a few pictures from some of the different contexts. As you will see, they look different. Even the layout is different, but all of them serve basically the same functions. On your left, you see the National Public Health POC from Sri Lanka. On the right picture, you see the Thailand Health Emergency Operations Center. The next one, please. On the left here again, you see the National POC from Maldives. And on the right top, you see from Cox's Bazar, where at a very tactical level, there's a public health emergency operations center, and the layout is completely different to the national centers. In the right bottom, you see EOC from Nepal. Based on the context and the need, it's basically situated in a container. And it's also, but whatever shape, size it may take, basically it the functions, operations, SOPs, the human resources, all basically follow the same fundamental principles. With that, let me go to the next slide where I would like to share a video with you. This is a fairly old video. In 2018, it was created, which will give you a glimpse of HEOC, how we have been advocating for quite some time. If you can play that, please, Anu. Sound, you might have to reduce. Increase, please.
Ma'am, as the video, there is no audio in the slideshow mode, so we will be directly playing that video.
Okay, fine. Thank you. Thank you very much, Anil. So this is a video which we had done a few years back when we were advocating for the establishment of HEOCs across the region. And with that, we come to the second part of the presentation where I invite my colleague Anil Bola to take you through the PHEOC framework very briefly. Over to you, Anil.
Dr. Bhola, are you there? As we are not able to hear you.
Anil, you're on mute.
Okay, so now am I audible?
Yeah, yes, sir, you are audible now.
Okay, so thanks, Sugi, for giving insight in incident management system and public health emergency operations center. Greetings to all the participants. Now, taking this talk further, it's quite obvious to all those who have worked in emergencies and are responsible for emergency response operations that health emergency operations centers are very critical for timely, effective, and well-coordinated emergency response. To have that kind of PHEOC, to establish it, to run it, maintain it, and to get the maximum output through these centers. So what we needed to have a global guidance document. And next slide, please. So that's what WHO came up through wider consultation and systemic review of literature and existing practices across different regions, different countries. From 2012 to 2015, all these happened, and then in November 2015, the global framework for a public health emergency operations center came. So it was to standardize all the processes and all the components that should be in the PHEOC. So this is a guidance document which is good for establishing these public health emergency operation centers and for the guidance of member states to set it up at national level or at sub-national level. And in the beginning, Rajiv also hinted upon that even this existing guidance document is at the stage of revision. So hopefully, learning from the COVID-19 pandemic, we may have updated guidance document on it. Next slide, please. So recognizing that the role of this framework is to provide high-level management-oriented guidance, and that in-depth technical guidance is needed to support it, the Emergency Operation Center Network convened two working groups meeting in October 2016 and March 2017 to develop two further technical handbooks that you can see in the screen. These handbooks were released in 2018. The third book is still under development. So the first one is to give guidance on policies, plans, procedure that should be in place at national level for setting up these PHEOC. And second is to maintain and upgrade training and capacity building for those who will run it and conducting simulation exercises, etc. So all those procedures are elaborated in these handbooks. The third one is being developed, so it is in process after learning from different experiences of setting up PHEOC in different countries and different context. Next slide, please. So in summary, we will take all these components that you can see on the screen, which are essential elements of the framework on PHEOC. And what Sugi mentioned, that based on incident management system, the PHEOC establishes sections and subordinate units within the emergency operations center as needed to manage the incident at hand. So it depends from one public health event or incident to another, and depends on the type of emergency, whether it is due to natural hazards or due to disease outbreak, or it is a mix of that complex emergency, flood in in a setting where a surge of COVID-19 cases are already happening. So it may range from small scale response coordination to the larger response operations. So next slide, please. We take it one by one. So legal authority. So this has to be, it has to be through some government directive or a policy by the national government. It has to be invested in the PHEOC. It will allow an entity to oversee the health emergency program and the planning and implementation of a PHEOC. So the legal authority can be invested in a public health department or ministry or other agency to manage public health emergency. So it may vary from country context, and also the level, whether it is a national PHEOC or subnational PHEOC, so depending on the context. And this authorization by the government or a directive will assist in or will elaborate for emergency coordinations for different public health emergencies. It will also clarify different roles and responsibilities of the experts from different sectors who will be participating in the emergency response coordination through the PHEOC, and all those mechanisms, SOPs, technical guidelines, and checklist that should be there available in the PHEOC. Next slide, please. Policy group, the second core component. The composition of the policy group may be addressed within the legal mandate for the PHEOC, as I said in the previous slide, or as a separate policy, but should be established prior to an incident. So this should be already in place. For example, in the ongoing COVID-19 context in India, we had this national COVID-19 task force. So that was kind of advisory policy group, and the policy group provides high-level policy guidance on overall management of the emergency and facilitates interagency and interjurisdictional intersectoral coordination. It is also responsible for endorsing requests from external resources and assistance, and initiating requests for assistance from more senior level of government or donors or international aids. So that add values to the PHEOC maintenance and running. Next slide, please. Steering committee is more like an operational group that will run day-to-day activities when PHEOC is activated for any health emergencies. In some settings, the policy group itself can act like steering committee. So it depends on the resources available in a country or in a particular setting. And as it will be highly engaged for running of the PHEOC emergency response operations. So this committee will decide what should be the size, type and scope of the intended PHEOC. They will decide what will be the structure of the incident management team, and they will pool in different expertise in order to respond to a particular health emergencies. And they will keep a tab also on different key performance indicators specific to a emergency response. So they will be responsible for developing monitoring and evaluation plan. Next slide, please. So when a PHEOC is activated for a particular hazard or a health emergency or a complex emergency, so how it starts? So initially, we need to have the risk assessment, situational analysis in the acute phase of the emergency response. We should have an idea about the prevailing hazards, vulnerabilities, exposure of people, and existing coping capacities of the affected community. WHO also does 4Ws mapping, which is like who is working on what, where, and since when. It's about the stakeholders and partners in the field. So that is to have an insight about the existing resources in terms of humans, health emergency logistics, or expertise available in the field. And after learning all these things, then humanitarian needs and priorities are also assessed. Under the impact of any health emergency, the health needs and priorities of the affected communities may change. So in order to develop a emergency response plan, we need to have an insight on the changed needs and priorities. And also in a for the National Health Emergency Operation Plan, we also need to have this kind of information to feed in. So planning through PHEOC is here what we can feel that incident management system is put into action or put into practice. A PHEOC operates on 3 types of plans. The first one, the PHEOC plan, it is as I mentioned how emergency response plan is prepared, and then in order to have a regular PHEOC plan that maintains, sustains, and runs it, activate or deactivate it, we need to have the response manual. So this first plan elaborates all these things, and it may have annexures, checklist, SOPs, or different forms that are used to coordinate an emergency response through the EOC. And event specific or hazard specific response and management plan pertains to identified and prioritized list of threats and hazards in a particular country context. And that is through all these rapid risk assessment or situational analysis. And a action plan through PHEOC that is incident or health emergency specific. So this may vary from natural hazards to disease outbreaks or other complex emergencies, or so depending on the emergency that we are dealing with. So what is required, and what strategic intervention should be there, what type of experts we need to deploy, what health emergency logistical requirements are there in the field. So this action plan will have all those components, and then it is put into implementation. Next slide, please. So this slide tells about the information system and infrastructures in a PHEOC. So usually we have a SharePoint that could be virtual, or it could be a physical repository that all those involved in running of an emergency response through the center can access. So in the emergency setting, in any context, two types of information and data and information flow. The first is relating to a particular event. If it is a disease outbreak, then maybe epidemiological information. And another type of information and data that we find in the response operations are more kind of generic, ranging from demographic, population affected information, geopolitical security, and transport related information for that particular context, and also information relating to emergency logistics and partners, stakeholders working in the field, and progress made so far and the challenges, etc. So depending on the information and how it is processed, we also need to make a decision in the PHEOC that this type of information will be handled by this type of expert, and the technical epidemiological information will be held by epidemiologist or health expert. So there are different situation reports or epidemiological bulletins. So all these decisions are taken in the PHEOC. The frequency of all this release of this in processed information is decided. So the focus in the emergency setting that we should prioritize that the existing health information system should be tapped, and there shouldn't be any separate or standalone information system. We shouldn't encourage implementation of such a separate system unless the existing surveillance system is completely damaged during a complex emergency. Next slide, please. So this talks about what we need in a physical PHEOC. So mainly a dedicated space which should be easily accessible and should be also friendly for differently abled experts. And you have seen the pictures in the previous slides. Information technology and telecommunication equipment, so depending on the needs, and sometimes we need to have the satellite phone also in certain context when you think that it is the acute phase of the emergency and communication should not be hampered in any way. The space which is labeled PHEOC should be secure, should be safe, should be confidential. So information should not just be available to anybody, and it should not be just open for anybody. So the thing is that those responsible for running it and working in a stressful environment and have to deliver response interventions in a standard way, and also honoring the deadlines as per the WHO emergency response framework. So those functions should continue without any interruption. and bare minimum what is required, there should be a dedicated facility manager and a telecommunication expert. Next slide, please. So this shows a comparison between three possible modes of or modalities of public health emergency operation centers: virtual PHEOC, physical PHEOC, and hybrid PHEOC. So virtual PHEOC, I'm sure many of you are fully aware now that these kind of EOCs were run during acute phase of COVID-19 pandemic. So most of the incident management team or incident management support team or the national level or sub-national level task force in countries, they had this virtual PHEOC. So it shows comparison across cost, access, safety, and data security. So you can see, I don't have to say each and everything on this. So physical PHEOC, we should have. The best seems to be now learning from the COVID-19 pandemic that hybrid PHEOC is good, but there are costs to each. Which virtual seems very cheap, not expensive, and physical PHEOC, we need to consider the non-recurring cost, the cost in that we require for establishing it in the beginning, and also recurring cost to run it and to maintain it. And accessibility, you can see, you are aware about the virtual, easily accessible, physical. So physical PHEOC, it should be in-person meetings, and all these IT equipment, screens or laptops, everything should be there. And for hybrid, it depends on the needs, when you want to use it as a virtual or when you want to use it as a physical space for EOC. And safety, yeah. So seems like good when high threat pathogens, communicable disease outbreak happens, then the virtual PHEOC is the best way to go for. And in physical PHEOC, because there will be proximity and people, there may not be some PHEOC's space may not be adequate enough to accommodate all the experts needed for a particular emergency. So there is a risk, health risk of if someone is carrier of any pathogen, then yeah. So on data securities, for virtual PHEOC, we follow cloud. We rely on that. Physical PHEOC, we can have in-house server in the centers. So that is good, but it also needs to be maintained. And hybrid, we can use commercial cloud services and data hosting server in the center itself. So both possibilities are there. So next slide, please. Yeah, for training and exercises. So even before a PHEOC is activated, so we may identify different staff in Ministry of Health or wherever a PHEOC is set. So all those staff may have different roles and responsibilities in case of any emergencies, and they may have a skill set, but all those skill set and training capacities, existing capacities, they need to be upgraded or updated time to time. For that, the PHEOC manager or who runs it should have a training calendar in place, and some identified online courses or on-site courses should be used to train. Or sometimes we get the new new staff or new focal point for a particular area to look at. So we have to train them. So, and in order to ascertain whether the staff are having operational capability to respond to any health emergency, some validation exercises can also be run from time to time. And there should be a dedicated funds allocated for non-recurring and recurring cost of the PHEOC. So in the beginning, I said about that policy and legal authorization. So those two components should cover that up. Next slide, please. So here comes again on the essential components that the frameworks talks about for establishing, maintaining, and running of PHEOC at any place, national or subnational or regional level. So you can see all these what we talked about, and the in charge or the manager for running PHEOC should have monitoring and evaluation plan. So whatever in situ infrastructures related items are there, or the capacities, existing capacities are there, they should be reviewed from time to time so that the PHEOC can run smoothly and efficiently. Next slide, please. So Anil, please, next slide. So for more information, you may like to browse through the links that were shown in the previous slide. Yeah. So this will apprise you about the incident management system, PHEOC, and also the trainings available for PHEOC and also incident management systems. So that's my last slide. Thank you very much. I will be open to any questions later on. Thank you.
Thank you, Dr. Sugandhika and Dr. Bula for such an enlightening presentation on different phases of public health emergency operation centers and the global framework for PHEOCs. And this current COVID-19 pandemic, it has already showed why we need to work on the management of public health emergencies. As mentioned during the talk, it is a tool in broader public health emergency management system. That is PHEOCs, and the role connection between PHEOCs and IMS was also highlighted during the talk, and the framework that was shaped by the World Health Organization was also discussed during the talk, and this PHEOCs as highlighted are also crucial to meet the commitment of the International Health Regulation 2005 that aim to prevent, protect, control, and provide a public health response to international spread of disease. So thank you very much to both of you. There are a couple of questions, and the first query is from Ms. Sarita Kumar. And ma'am's question is that how to ensure that the international standards that are set for public health emergency operations centers, they will work at every level. There can be some challenges in implementation of this framework depending upon the regional attributes. So what are the additional add-ons to this framework? Those will help in smooth adoption of this framework at any given place.
Yeah, so may I reply?
Yes, sure, sir.
So the framework gives a broader outline considering all the different settings, different practices, and different context. So that's how the first one, the global framework of 2015 was developed, and we have learned about different contexts now, as Sarita mentioned about this, that a particular setting, a regional context may be different, and there is need to adapt to it. So based on that, based on the feedback received from the field from different regions, now these international standards or international guidelines are being updated. So whatever will be coming up or whatever is existing, that considers all the field requirements, what we know. And that's how it is put. If something new happens, then depending on the needs, depending on the resources available in a particular context, so EOC can be established and it can run. We have shown the pictures and in the video also. So different countries may have different kind of setting, and they may have different kind of equipments, and maybe a different kind of expertise available within the country. So even the human resources which are dedicated to run the PHEOC may vary from place to place. So at regional level, it may be at the here for our region, for 11 countries, we may have advanced PHEOC, and at country level, it may look different, and subnational level, based on the existing risks, hazards, and threats for that particular setting, they may decide, okay, our needs are this, so we will have only this much, and it should be adjusted. So that's how the framework is flexible, but it considers all the attributes or all the requirements of a particular setting or in relation to a particular emergency response operation. I hope I answered it.
Sure, sir. And sir, next question is from Mehak. Is public health emergency synonym to disaster? And if not, what is the criteria to differentiate between a public health emergency and a disaster?
I will give example of some countries where there is a emergency operation center and also public health emergency operation center. So in these slides, we said EOC can be used for any emergencies that may not include health emergency. It could be simply managing a disaster, impact of disasters, and so the National Disaster Management Authority or the provincial or state level disaster management authorities may decide to run the operations, rescue relief and response operation through the EOC. But PHEOC is mainly concerned about health emergencies, public health emergencies. So in certain situations, both natural hazards and disease outbreaks are both combined, and so Ministry of Health and disaster management authorities, they can work together. It happened in Maldives. They decided to co-lead the emergency operation center during COVID-19, and there were difficulties in Indonesia. So also the advanced country Thailand, they had advanced public health emergency operation center, but because of the protocols or existing protocols or policies, so they couldn't connect well with the NDMAs. So there were again coordination problem between Ministry of Health and NDMA. So these kind of situation may arise in different settings. So EOC, let's say at district level, there is a disease outbreak, acute watery diarrhea disease outbreak, or maybe measles outbreak. Then the deputy commissioner calls all the stakeholders or different line departments sometimes to run the emergency response. That becomes a emergency operation center. Yeah, so it depends on the situation and the decision made by the administrators. Yeah.
Thank you very much, sir, for answering the queries of our participants. So that's all for the Q&A sessions. And I once again thank both our experts. Despite their busy schedule, they pause their busy schedule and they give us this opportunity to learn from their expertise. So thank you very much, sir. So moving to the next presentation. For next presentation, we have with us Dr. Akshay Dhariwal. who is advisor emergency management VHS CDC and former director NCDC, and served Government of India as Central Health Service Officer for more than 3 decades. And Dr. Dhariwal also assisted many states, many Indian UTs in the field of public health emergency management. And today we are fortunate enough to have him with us. And sir will be sharing his decades of experience, basically field experience gained from managing health emergencies through state strategic health operation centers and EOCs. So with these words, I pass on the stage to you, sir. Over to you, sir.
Thank you, Mr. Anil. At the outset, my sincere thanks to the organizers, and in particular, Director NCDC, ED NIDM, Director CDC India, and in particular, Dr. Rajiv Sharma, who is the pattern of this webinar series. Am I audible?
Yes, sir, you are audible.
Right, thank you. So my task had been made easy by the previous speakers. So I am here, as has been said in the introduction, that I have worked as Director, National Center for Disease Control, and I owe my gratitudes to all the directors of NCDC, in particular Dr. Shivlal, to whom I consider as my mentor. And I'll be sharing of working with all those dignitaries and the professionals in the field. So what I'm trying to do in my talk of next maybe 20 minutes or so is regarding whatever has been said.
Excuse me, sir.
Yeah.
Sir, kindly make the presentation in slideshow mode.
Okay, okay. Just a minute. Is it better now?
Yes, sir.
Yeah. So in next 10-15 minutes, I'll be talking, sharing my experiences, my own experiences. And in particular, I am saying that I have been involved in not only investigation, but in assisting to the states for the containment and other aspects. And not only the containment, but from the point of view of the preparedness, where the concepts of public health emergency management and in particular the incident management system, the incident response system, what we have been using here, and application of these concepts through PHEOC or EOC. Now, this I would just touch upon to share that whatever has been said by the previous speakers, we have to see from the point of view of the implementation now, and particularly in Indian context. And that is why means I will take you through to share my views that where were we in past, where we are, and what are the way forward. Now, if we look at the major outbreaks, infectious disease outbreak over the period of time, which have paved the way for system strengthening in the country. Means long back in 1897, when bubonic plague outbreak was occurred, then at that time the Epidemic Disease Act, one of the instruments which is still valid today. And we have seen during COVID-19 pandemic also that it was promulgated and some amendments were done because the 1897 was lacking in some of the aspects. Similarly, after the natural disasters, particularly Bhuj, the National Disaster Management Authority was created. So what I am trying to say, and we have seen in the current COVID-19 pandemic also, so many things happening, and again making inroads for system strengthening, etc. So in that background, let's look at what are our strengths. Our strength is that because of these changes, the system I would say the staff and the infrastructure which have been developed over the period of time, the surveillance and response system, which is a well-established integrated disease surveillance program in place nowadays, which take care of epidemic-prone diseases, which are the most important cause of public health emergency in India. Now, recently, there has been a development that the real-time reporting has been started through the Integrated Health Information Portal. And I understand as a part of this series, there would be a one-day webinar on the Integrated Health Information Portal. We'll be discussing more in detail. So at this stage, I'm just mentioning that we have a very strong surveillance and response system in India, and of which the multidisciplinary rapid response team, again, which paid dividend, and with the help of WHO, the RRT training module, particularly in context of COVID-19. So all those things, and in 2009, when we had H1n1 pandemic, then a policy decision was taken to start the Strategic Health Operations Center at National Center for Disease Control at NCDC. And that had been now in operation and again was utilized for various public health emergencies which we are facing. And I would also like to mention that this term of EOC, PHEOC or CHOC, I would like to make it clear that in past also we were having some system which was called as the control rooms, the command rooms, the command centers. So still, I would say as on date also, different states, and even at the block level, we have these control rooms, which now the government has thought of transforming it into the public health emergency operation centers. And some of the states they have already, and I'll be giving examples of those happenings in recent past, particularly in COVID context. Then under the Disaster Management Authority, for the same connotation, the Emergency Operations Center is used. So what I'm trying to say is that we have a well-established system in which the PHEOC is the term used from the public health, from the health side, and Emergency Operations Center from the disaster side. Now, this is one initiative about which I understand all of you might be aware and might be following it, that under Ayushman Bharat Health Infrastructure Mission, ABHIM, there is now a commitment from the Government of India side for which budget provision has already been made for setting up of 15 health emergency operation centers. Now, sharing my experiences and again linking with the use of the ICT and other aspects, that during plague outbreak in 1994, we had, I would say, a lot of problem where the exodus was there, hoarding of tetracycline was there. There was problem of the face mask, etc. availability, which we have seen during COVID-19 also. But at that time, this culminated into the policy changes for surveillance system strengthening, lab strengthening was done, lab network was established, again, which was very helpful during the COVID-19, that we have a very strong network of laboratories where the PCR could be done, and then subsequently the genomic sequencing, etc. has been done. The information technology and all the districts were connected by the satellite link. So all those things. So these are some of the aspects. Similarly for dengue, I would say intersectoral coordination as a part of the program, extensive education, clinical management guidelines, which are needed for the public health emergency management, and we'll be seeing that under different functions of PAM, we need to have these aspects. So these were very much, I would say, affected and led to the policy changes, and program guidelines were revised, and the actions were taken accordingly for building the system, and system strengthening took place. A few examples of the natural disaster, Odisha super cyclone I would like to mention, and I would like to mention, link it with the first bullet, that National Disaster Management Authority was established after Odisha super cyclone only. So that's one example which we have seen ourselves, that what was happening before that and what happened after that. So Disaster Management Act also was enacted and had been promulgated various times during COVID-19. Also, we have seen that how useful this powerful tool was there. Then incident response system modules training EOCs were established again under the disaster management, as I said, under the NIDM. Then Japanese encephalitis is another example which I myself have seen, that how the system has been strengthened, how the policy decisions have been taken, and we have seen the outcome that presently we don't see Japanese encephalitis outbreaks in news, particularly from the northeastern states or from the Purvanchal area of UP. So that also, the third, I would say, the experiences which we had is during the 2019 H1n1 pandemic, where One Health approach, vaccination, and shock, as I mentioned, was established, which is being used for the public health emergency management. In the COVID-19, we have seen all the aspects written here, particularly the vaccination, and at the highest level, the review, decisions, and commitment. And you might be knowing that today, because of this upsurge of cases in some of the states, the Prime Minister himself has talked to the chief ministers of different states, and there was a meeting to review the situation. Now, here are two live examples where we were involved. And again, I vouch that I myself have been and have witnessed the happening at these places. What has been said by my colleagues, Dr. Sumantika and Dr. Anil, about the EOC, that how using all those concepts which has been narrated, may it be using the handbook or may it be using the framework, the state of Tamil Nadu established a state public health emergency operation center, again, which was responsible for not only collecting information, but taking care of the day-to-day, and I would say on hour-to-hour basis, because they have all the components, and even from the community, the direct feedback was coming, and whatever was needed in different nook and corner of the states were being taken care of. Then we have seen, means you would agree that India is a country where we see conglomeration, large conglomeration, and particularly we have been seeing during the Kumbh Melas, may it be of Ujjain, may it be of PHEOC, may it be of Haridwar. Last year, when this first wave was almost, I would say, on the declining phase, and that particular point of time when Kumbh Mela was there, the second wave just started. It was not known that it would culminate into such a severe, I would say, problem that we have lost our family friends, maybe our family members. So, but at that particular time, everybody was apprehensive that what will happen in that conglomeration large number of population, large number of persons would be gathering, would be taking dip with the Ganges. So again, the government of Uttarakhand requested NCDC, and with the help of all the stakeholders, the EOC was established in field. That is why we are using word field PHEOC. As Dr. Anil has also mentioned about different types of PHEOC, may it be virtual, may it be physical, may it be hybrid. So this is another category that even in field situation, the temporary PHEOC, what we have been seeing in that situation, it was established, and again, it was responsible for sort of collecting information and helping to the local authorities there that these actions has to be taken. They generated early warning signals, and as a result of that, no major disease outbreak was observed. We could contain it. It's not that nothing happened. There were occurrences at some places, clustering of diarrhea cases, clustering of fever cases, but because of this field PHEOC, and in particular the IMS concept there, it has yielded that no major outbreak was reported. So in summary, what I am trying to say is that the lesson learned from our experiences of working at NCDC or at NVBDCP at different states, in different situations, you would all agree with these 6 bullets that there is tremendous negative economic impact on trade, travel, and tourism because of these problems. May it be of infectious disease outbreak or may it be natural disasters. And for this high-level commitment is crucial. That is what I have demonstrated in previous projections, that an act, dedicated organization, dedicated authority for this particular subject, disaster management authority were established, and the intersectoral coordination, because it cannot be done. It cannot be done in isolation, public health emergency management. We all should understand it very clearly that the epidemiology of different diseases, epidemiology of different public health programs tells it that it is multifactorial. So that is where the need of intersectoral is very important. Global partnership, rapid sharing of information, again that we have seen not only in COVID-19, during H1n1 also, and during Nipah problem also, we have seen that how important is the rapid sharing, so that not only we, the others are also protected. Then we have seen, means again taking example from Gujarat or from Siliguri, Nipah outbreak, or in last year we have seen panic and hysteria that should not be allowed. Means we have seen it, there is a need to handle it, and there is a solution in the FAM principles, I would say, and in particular the IMS also, which are to be talking in next projections. But the bottom line is that it's possible to contain if the response is swift and evidence-based, like we have seen in the functioning of SHOC at NCDC, that whenever some problem is there, the SHOC is activated, and again there are the SOP, there are guidelines that at what stage and with what inputs the SHOC has to be activated. So all those things are the lesson learned, that we are mature enough and we are taking action accordingly. And on the whole, now for everything, what we need is the public health infrastructure. We need health system strengthening, and this PM Abhim, as I mentioned, is a step forward in that direction. Now, just a few words about the FAM, the Public Health Emergency Management which is the pillar. And PHEOC, to my mind, is one of the vehicle to take forward the basics, the principles, the concept of public health emergency of management. And broadly, we have these 4 pillars. The first one is, as I have been using word integrated management, incident management system. But in India, means of late, we have started using IMS, but earlier we were using response system. If you look at the NIDM documents of 2015 or so, or before that, most of the documents are titled as the incident response system. We also use incident command system. So to my mind, means we have been getting queried quite often, what is the difference between these 3? I usually respond that they are the same. It's a question of how do you perceive it and how do you use it. Again, bottom line is that we need to practice the basic concepts of IMS. So in the next projection, I'll be talking a little bit about, although I saw Dr. Sumadika had already covered this aspect. The Public Health Emergency Operations Center or Strategic Health Operations Center, as is the term used in India at NCDC, are the vehicles to take forward. And again, we have seen, and today's topic is to talk more on these aspects. System strengthening is another thing, and capacity building, again, I would like to mention. And I would encourage our young colleagues, because I inquired that who all are attending this webinar. I was told that more than 2,000 participants are connected, out of which about 25% are from the medical background. And I understand many of these persons may be from the public health background. So they can take this as career, public health emergency management professional development program. PDP stands for professional development program. And this is, again, to my mind, is an emerging specialty in the public health. And one can take career in building, as Dr. Anil Bhola, I know he has taken up this as a career, and there is a bright future in it. There would be an opportunity for fellowship, there would be opportunity for internship, and there may be in time to come certain positions at not only in the government sector, in the other sectors. And again, I would like to mention that a lot of persons, when I looked at the profile of those who are attending, a large number, means I'm just sharing with the organizers also, and I compliment them that a lot of persons from the private sector and a lot of students are also connected, numbering 64, 51 from private and 44% from the government sector. So in summary, this is one thing which we have to keep in mind. Now, I understand in the interest of time management, I would just mention a few more things. That incident management system where...
Excuse me, sir.
Yeah.
Sir, just gentle reminder that only 5 minutes are left.
Right. I thought that question answer would be after the presentation. That is why, okay, I will just finish it in another 2-3 minutes. The public information officer, safety officer, and liaison officer. These are the 3 important management functions which we have observed, and our experience is that if these persons are in place, then a lot of problems which we have been facing during the public health emergency can be attended to. The public information officer basically is the person who advises on the information dissemination and media relation, and he develops the communication product. The liaison officer is the person who coordinates with the stakeholders and serve as a point of contact for representative from other agencies. The safety officer, I would like to use the word safety, while in document security officer is also used, but safety of the healthcare workers is very, very important, and this person has to be there as a part of the management function. So in summary, this is my last slide. The take-home messages are that these public health emergencies would continue to occur because of various factors about which we know: the population growth, the climate change, the international trade, travel, and for that purpose, risk assessment, prevention, mitigation, preparedness, response, recovery, the typical that FEM cycle has to be adopted. The shock, which we are the subject of today, is essential, and for that purpose, IMS is a standard organization model. So I would stop here, and thank you everybody for patient hearing. Thank you.
Thank you very much, sir, for sharing your past experience, your learnings of on-field experience of public health emergency operations center from place like Tamil Nadu and Haridwar Kumbh Mela. That will definitely help us to fill the gaps and to further strengthen the systems of public health emergencies in our country. Sir, there is one question from our participant, and this question is from Jay Sharma. What are the major challenges when you are setting up an EOC in cultural setup like Kumbh Mela? Do the public health emergency operations center in these places like Haridwar also cover human stampede that has great chances to happen in such places?
Yeah, very right that we need to understand beforehand the problems which are likely to happen. And again, from our experiences, I would like to mention that one of the problem is the location of the place. We need to have, means there are guidelines which says that this much space is needed and that space should be accessible, that place should be safe. So that is one problem which we have to keep in mind while working for PHEOC. He has also mentioned asked about that there may be stampede, etc., particularly in large conglomeration. Yes, and that is why means these aspects, monitoring and that basically would be handled by the law enforcement agency, but location, etc., has to be such that these aspects are taken care of. Hope I'm able to answer the query of the participant. Yeah.
Thank you very much, sir. That was the only query from our participant. And thank you very much for joining us and enlightening our participant. So moving further, now I request Professor Surya Prakash, who is head EOC and CBRN and GMR division NIDM. I request sir to kindly provide his concluding remarks of this webinar. Over to you, sir.
Thank you, Anilji. First of all, I must say thanks to the distinguished speakers who have joined with us today and shared their rich knowledge, experiences, ideas, and innovations in this particular field on establishment and functioning of the public health emergency operation centers. With due regards to the patrons of this program, Shri Taj Hasan ji, Executive Director, NIDM, Dr. Sujit Kumar Singh ji, Director NCDC, Dr. Meghna Desai ji, Director, Country Director, CDC India, and also the dignitaries and chairs of the program, Dr. Himanshu Chauhan, Dr. Rajiv Sharma ji, and Dr. Shivlal ji, former Director NCDC, and as well as the distinguished speakers, Dr. Sugandhika Pereira ji, Dr. Anil Bhola ji, and Dr. Akshay Dhariwal ji, who have all shared their rich experiences with our delegates and the participants. And this occasion, they actually also indicated us the WHO's perspective regarding the concepts and framework for the establishment and functioning of public health emergency operation centers at different levels. In addition, Dr. Dhariwalji actually indicated his experiences with the Indian conditions, how during the various programs and health emergencies, the emergency operation centers have been working, particularly in the earlier times when it was command and control systems, which were functioning either as incident command system, incident management system, or the incident response system as per our terminologies in disaster management. I like to just share some of my personal views also on this occasion, that whenever we are talking about emergency operation centers, be it health emergency operation center or any other line departments or ministries emergency operation centers, normally we use a term called control rooms for these emergency operation centers of the respective ministries. And while establishing those emergency operation centers, we actually have to look into, first, as said by Dr. Akshay Dhariwalji also, the location of that emergency operation center has to be safe from any kind of potential emerging or existing hazards so that it can remain functional. So first, the location, wherever it is chosen at whatever level, the safety perspective must be given due priorities besides the accessibility, economics, and other feasibility options in terms of environment or socio-cultural perspectives of those areas. Plus, whenever any system is physically erected, we always go for structural and non-structural resilience of those structures. And now when we are talking about emergency operation center, there had to be a standard design for its appropriate functioning, which should actually be conducive to all kind of emergencies. The ways it is required to communicate physically as well as through the IT or ICT medium, it should be very much feasible and should be able to carry out all the functions that are required to execute during the emergencies. So the physical stabilities and safeties of the structure must also be ensured that it should not get affected by any of the geographical hazards, particularly the floods, which had happened in the past. We have seen several of the hospitals and health infrastructure getting affected by floods, then earthquakes, landslides, and other kind of disasters. So that should also be taken into account while establishing and making them functional as EOCs. Then the third is that the non-structural elements in terms of the equipment and the resources that are actually required for these EOCs, they should also be fully well-trained and equipped staff to use those equipment and resources so that the EOCs can function very efficiently. Further, in order to work with those resources and equipments, sometimes we need some external support systems. They are vital requirements without which these resources cannot function or these equipment cannot work. So therefore, we need to look into those perspectives. For example, power supply is an inevitable element which is always required to be available for our emergency operation centers to function. For power, we are also looking into alternative power systems in case the power grid fails and there is an health emergency. Then how would we maintain the supply of power for emergency communications in disastrous health situations? That is also required. Plus the communication devices, they also sometimes get stuck or choked or congestion in the networks. So how we would establish that the network congestion, signals, and other issues, they are not a hurdle to our emergency communications. Because in any emergency operation center, communication is the first thing that would be required and the formats for communication, the protocols for communication, and the coordination mechanisms in pre-disaster situations. They are all the prerequisites for efficient functioning of any emergency operations center. Further to this, we are establishing these centers as part of the activities, say under the ministry's plans, Ministry of Health, Family and Ministry of Health and Family Welfare, or the collaborative partners like NCDC, CDC India, or NIDM. But is there a systemic provisions for other ministries to pool their resources or interact with them? So I think we need to actually integrate these emergency operation centers with the emergency operation centers of other line ministries or departments, as well as our district level emergency operation centers, which are designated for the disaster management activities, or the state emergency operation centers, and the national emergency response center. So these linkages will actually help them to pool those resources which may fall scarce or short during the health emergencies. So they can actually share those resources and help each other in times of crisis, emergency, or disaster situations. So those kind of protocols and collaborations also must be looked into while establishing these kind of PHEOCs. Further, whenever we are working, there is a need to actually have the systemic recognition that they should be actually recognized by our DOECs also. This is two-way. What I'm stating is that the DOC in health emergencies can also seek help from health emergency operation centers, because they are the specialized centers where they will have a skilled, equipped human resource which can understand better the health emergencies and crisis situations or disaster situations than the people in our own disaster emergency operation centers, where people with different backgrounds, they are working for those functions. So this is what we need to do. And besides that, the other thing I would suggest is that not only considering the government departments or the local communities, but let's also consider the public-private partnership and corporate social responsibilities to be included into this. Many of the organizations, particularly the industrial sector, I know, they are also establishing their emergency operation centers for their contributions. So therefore, we can also actually get them involved into these processes, so that there is an interchange and exchange of ideas, resources, and the innovations. A lot of new technologies are coming up, which can also help us. And these new technologies need to be inducted in our emergency operation centers for effective and efficient communication and outreach, as well as in the peace times when there is no disaster, we can actually work with the communities at large in those areas to enhance awareness and preparedness amongst the communities, community-based organizations, non-governmental organizations, and all such other stakeholders. So besides the views which have been expressed by the distinguished experts, Dr. Sumedrika, Dr. Anil Bholaji, and Dr. Akshay Dhariwalji, I just wanted to these some of the additional points which may also be considered. And I hope with this information, our delegates and participants will get enriched, as said by Dr. Dhariwalji, that some kind of new courses and development of professional development programs on public health, emergency management, and disaster management may also help us to actually get new professionals with better knowledge and information and equipped with better skills, would be very useful for our society and environment as well as the nation. So we wish all the best. Since we have been joined by people from other countries also, we'd like to learn lessons from other countries who have implemented these kind of public health emergency operation centers, and what are the good or the bad practices which need to be considered. So good practices we like to adopt, and bad practices we like to eliminate or reduce to the extent possible. So these lessons learned from the past experiences from other areas would surely help us pave our way to establishment of efficient all-time 24/7 by 365 days functioning of our public health emergency operation centers. I wish all the best to all. Safe, healthy and good quality life on an equitable, justifiable and right-based manner with good fraternity. Thank you for providing me this opportunity. And I would also like to thank CDC India and CDC and WHO for collaborating with us in this webinar and sharing their ideas with our delegates and all the participants. Thank you, one and all. Back to you, Anil.
Thank you very much, sir, for summarizing the essence of this today's webinar in your own words. Besides your thoughts, your ideas on the requirement of EOCs covering all its aspects. So once again, thank you very much, sir, for joining us. So with this, we draw the curtain of today's webinar on overview of WHO's PHEOC's framework and global common minimum standards for it. But before saying adios to you all, I take this privilege to propose vote of thanks to our distinguished dignitaries and our experts and as well as participants of this webinars. So at the outset, I would like to thank Dr. Sugandhika Pereira, who is a Program Area Manager, Emergency Operation from WHO, and Dr. Anil Bhola, Consultant, Emergency Operation, WHO, and Dr. Akshay Dhariwal, Advisor, Emergency Management, VHS, CDC India, as well as former Director, NCDC, Government of India, for providing us this opportunity to learn, to gain from their respective knowledge, their respective experiences, as well as expertises. And I would also like to thank Shri Taj Hassan, IPS Executive Director, NIDM, Dr. Meghna Desai, Country Director, CDC, Country Office, India, as well as Dr. Sujit K. Singh, Director, National Center for Disease Control, Government of India, for their directions, for their supervision in organizing this webinar series. And thanks are also due to the co-chairs of this webinar series, Professor Surya Prakash, Head GMR and CBR Division NIDM, Dr. Himanshu Chauhan, Joint Director and Office in Charge, IDSP and CDC, and Dr. Rajiv Sharma, Public Health Emergency and Lead Emergency Management, CDC India, for their continuous guidance on how we can improve and make this series fruitful. So thank you very much, sir. And I would also like to thank our participant for joining us and for their active participation in the webinar through their queries, through their valuable questions. And in the end, I would like to thank GMR team from NIDM and CDC team for their continuous support, their collective actions in the background for organizing this webinar series. And this is to inform to all our participants that to further consolidate on the objectives of this ongoing webinar series, on the next Wednesday, we will be coming up with a webinar on public health emergency operation centers that will be focusing on information technology like hardware, IT hardware, software management, security, and infrastructures. And the same link which you have used for to join today's webinar, it will be working for next webinar as well. So all are requested to kindly mark it in your next week's schedule and join us for next week webinar as well. So thank you very much. And with this, we conclude today's webinar.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you very much.